Good. So thanks, Greta, for inviting me. The title of my talk is You Got Yourself Involved in Leading Kitchen Group Medical Visits, Now What? And I actually wanted to title this, Lisa Grant Got You Involved in Leading Group Medical Visits, Now What? And I say that kind of jokingly because, I want to give Lisa credit because she was the person who asked me to do this and, a few years ago, and I had no idea what to do and what it meant. And I want to acknowledge all the people that, put the group medical visits together and the kitchen together. And I know there's a huge amount of background work that Lisa did and many others did, but to get this going, and it was easy for me to just come in and do my thing. But I want to thank Lisa. It's been a real pleasure to do this, and it's been a great experience for me. And so I want to acknowledge Lisa specifically for getting me involved in this. So what I thought I'd do is spend a little time talking about how I see the group medical visits. And currently I'm doing it virtually because of COVID, which has been successful, but I wanted to kind of go through how I think about cardiology. My groups are typically with patients who have established coronary artery disease or have had vascular disease. And it's sort of the idea of how do we involve them in a group medical visit and what do we do? So that's kind of the theme of the talk today. So I remember when we first started this, and Katie, as the health coach who works on this with me, and I also want to acknowledge her help in this and some of the things she's taught me. But one of the things said, what's the point? What are we doing here? And I think there's a lot of points, but these are just sort of some ideas that people with heart disease are really concerned about their risk of either having had an event and whether they're going to have another event and what's their own personal risk. They want to learn about heart health and whether what they're doing is right or not. They want to ask questions and they want to have some time to ask questions about their heart. They want to learn from others and they want to make change, which is what probably Katie taught me the most, is that it's not that people don't know what to change, but they don't know how to change. So I think that's one of the other things we focus on in the group medical visit. So just some bad news to start with. This is sort of a slide looking at deaths attributed to cardiovascular disease. And when I was in training here in the late 90s, we actually saw a decline in deaths from cardiovascular disease. But this latter half of the curve, which extends into 2021, really has shown this concerning trend towards an increase in deaths from cardiovascular disease. And I don't want to spend time talking about why this is. I think there's a lot of reasons for it, but clearly we seem to be headed in the wrong direction. And this is from an article in the New York Times where they looked at a paper published in JAMA that described that after decades of major progress in reducing deaths from diseases of the heart and blood vessels, the decline in cardiovascular mortality has slowed significantly. And this was from a CDC report. And the researchers called their findings alarming, suggesting that cardiovascular benefits from interventions may have reached a saturation point and that further improvements depend largely on changes in society and personal behavior. Now, I think my cardiology colleagues would say that there's been some good progress in terms of medical cardiology interventions. For example, transaortic valve replacement, which is a non-surgical approach to aortic valve disease, has been a real godsend for a lot of patients who weren't felt to be surgical candidates. But I do think that this focus on changing personal behavior is really a significant part of, turning around this trend in cardiovascular mortality. This is the other piece of bad news, and I think we all kind of know this in many more ways than one, but that we're spending a huge amount of time on the electronic health records. So from the Annals of Family Medicine, they reported that nearly 6 hours a day was spent interacting with the health record during and after clinical hours, which is a huge amount of time. And I think this is a realistic estimate for most of us. And then from the Annals of Internal Medicine, physicians were spending only 27% of their time in direct face-to-face counseling with the patient and 49% of their time on the electronic health record. So that's some more bad news, and we're also facing burnout in the profession as well. So I want to focus on what the good news might be. And this is sort of a list of things that I'd like to kind of talk about during this presentation. So first of all, I do believe strongly that group medical visits might be able to help both of these problems that I just listed. And that assessing risk is becoming, I think, an important tool in cardiology. We're better equipped to identify a person's individual risk for heart disease, and that identifying this risk early is really where a lot of the benefit lies and what our patients are most fearful of. Am I at risk? And then this idea of personalized care, which I think is evolving and is more unique. But for me, I think it's this idea that I've learned that what works for me may not work for you. So a lot of our patients have been through frustrating a process of trying to live a healthy life and do the right things, but they are having struggles with making change as opposed to not understanding what change they need to make. And I think we're also discovering how to make these individualized recommendations that are going to be important in the future. And then again, making change, I think, is really the focus of the group medical visit, and that changes in personal behavior may be able to change this tide of cardiovascular disease and death. And then finally, the concept in cardiology that I think is new is that we're recognizing that it's about the vulnerable individual. And I'm going to spend a little time talking about what I mean by that. And that it turns out that the same changes that might improve someone's cardiovascular risk and health turn out to also prevent some of the more common chronic diseases, cancers, diabetes, arthritis, cognitive decline, depression. So I call this a 2-for-1. If you make changes that are beneficial for your heart, you actually find out that it reduces your risk of these chronic diseases as well. So what about group medical visits? Do they work? I think there is some data to suggest that they do work, and I'm going to show you a little of it. I do think that this has been around for a long time, and if you dig through the literature, there's not a huge amount of data about it. So I do think there's an opportunity for us to potentially try to justify the group medical visits and do some work in that arena. And if somebody is interested in working on that, I've got some ideas that I'm going to share with you. So what are the potential benefits? I've already listed some of them, but it turns out that most people would agree that face-to-face teaching and even a video-based exchange of information is one of the more efficient ways for patients to gain information, and they do it better in a group environment. That adults learn better in an interactive group than usually on a one-on-one. That this concept would allow us to have more time with our patients. Our sessions are 90 minutes as opposed to, a 15 or 20-minute clinic visit where half the time is spent figuring out what medications the patient might be taking and not actually spending much time with the patient with their questions. There's some evidence for better outcomes, better access, more appointment times. My clinic is, I don't have an opening until April at the beginning, and we just started February, and I think a lot of people feel this way. And then certainly this has created physician happiness from my point of view. I really enjoy the visits. Katie and I, when we finish each one of the sessions, kind of usually touch base, and we're always just happier. We just feel better about what we've done and how, and watching the patients sort of make change and get something out of it is a real pleasure. Group medical visits, there is some evidence that they save money. I don't want to spend a huge amount of time on this, but these are just 4 different studies showing some financial benefits. Dean Ornish, who's popular for his really aggressive low-fat diet, in a group medical visit showed $17,000 per patient savings in foregone cardiovascular procedures over a 3-year period. John Kabat-Zinn, $724 per patient using a mindfulness stress reduction program. Herbert Benson and 4,400 patients using a relaxation-focused group medical visit showed 43% reduction in use of drugs, emergency room visits, hospital visits, and physician visits. And then this Kaiser Permanente trial in Colorado using a shared medical appointment showed fewer physician calls, fewer ER visits. So I think these are some benefits that would help the whole medical system, which is overwhelmed with patients and visits to the ER. And then there's some numbers. The numbers are kind of hard to come by, and I think this doing research looking to try to change things like blood pressure is difficult, although there are some trials that show blood pressure went down with group medical visits. Weight loss has been shown, although it's really hard to show weight loss in a short time period. We've certainly had some very big success stories with patients who attended our group medical visits. And diabetes care is probably one of the more popular group medical visits showing some benefit. This is a meta-analysis of a bunch of smaller trials using group medical visits and showing a reduction in hemoglobin A1C. So I think overall group medical visits work and they're beneficial. The other issue I think that we try to address in the group medical visits is helping people with this idea of what risk am I at and what's my risk going forward and why this is important. And I want to just present quickly a patient experience. So this is a 56-year-old woman who I met on Christmas Eve several years ago. She, about 2 months prior to me meeting her, was in the ER, or excuse me, saw her primary care doctor with some exertional chest pain. She had a stress test. She actually exercised to a normal functional capacity and did very well on the treadmill, but she did have some chest pain at the peak of exercise, and she had a perfusion scan that showed ischemia. And so she underwent a cardiac catheterization. She had severe narrowing in one of her main coronary arteries, and she had a coronary stent put in. But this whole experience really threw her for a loop. She was a young woman. She had no idea that she had any risk at all. And as it turned out, after this, the dust settled on this, she was pre-diabetic, she was hypertensive, and she had dyslipidemia. And it turned out she also had a family history. Her father had had a heart attack, but she never considered herself to be at risk. So one of the highlights was that she really didn't recognize her risk. But when I saw her, she was having atypical chest pain, and this sort of continued on. She was admitted. She had another heart catheterization. Her stent was patent, but she really had a huge amount of anxiety about this, and this really kind of completely altered her life. And because of her experience, she actually contacted one of the local news stations and wanted to tell her story. And so the local news person put both her and I on television to talk about her experience. And as my experience with television interviews is, sometimes they don't go the way you want them to go. And I was sort of focusing on evaluating the risk and identifying risk and focusing on prevention of future events. But the interviewer personality sort of took this to say, hey, if you think you might be at risk, you really got to demand a test and get a coronary angiogram. And I find a lot of our patients really think this way. When am I going to have another heart catheterization? I had a stent put in. Don't you need to check that? And or my dad had a heart attack. Shouldn't I have a heart catheterization? So I want to spend a minute sort of talking about this idea of what makes the heart most vulnerable, because so many of our patients really struggle with this concept, and even some of our physicians struggle with this. So is it about the presence of a coronary stenosis? Here's an angiogram of a person who had a stenosis in the circumflex artery. Is it about ischemia on a stress test? And this is a nuclear perfusion scan with an abnormal blood flow to the inferior wall of the heart at stress, and then it reverses at rest, consistent with an ischemic abnormality. The reality is, the answer is it's about the amount of coronary artery plaque that's present. So this is a CT angiogram of a patient. This is the left main coronary artery. This is the circumflex artery going down here to the right, an intermediate branch artery, and the left anterior descending artery going off here. And you can see this huge amount of calcified plaque in this vessel. And it turns out that the most important thing in terms of risk is the disease burden, and not so much the presence of a stenosis per se or the presence of an ischemic defect per se. And this is kind of borne out in multiple studies, most of them being in coronary CT literature, but this is just one example of a population of patients with an actual moderate intermediate risk of or pretest probability of disease, 62%. And these are patients who underwent a CT coronary angiogram, and you can see that this is mortality. In blue, if you had normal coronary angiogram, your prognosis was excellent, but depending on how many disease blood vessels there were, the risk, there was a gradation of risk, so that the worst risk was if you had 3 vessel disease or left main disease. And I think one of the points here is that a good percentage of these people actually had mild stenosis, so less than 50% narrowing, which wouldn't be picked up necessarily on a stress test. But these patients clearly have coronary artery disease, and they are at risk for events. So this non-obstructive disease is important to identify. And this is just another example of sort of why this maybe non-occlusive, non-obstructive disease is important. Here's a nuclear stress test in a patient that's complete. Take my word for it, it's normal. There's normal blood flow at stress, normal blood flow at rest. And we'd say, well, this is a normal study. Go on your merry way. You don't have to worry. But in the background, you might have 1 of 3 different patients. Here's a patient with a normal stress test that has completely normal coronary arteries, no plaque, no calcium. Here's a patient with a normal stress test who has 3 vessel disease. There's a small amount of plaque you can see in the left anterior descending artery, some plaque in the circumflex artery, this little fleck of calcified plaque, and then also some osteo-right coronary plaque. So this person actually has 3 vessel coronary disease, but a normal perfusion scan. And then here's a patient who has non-obstructive disease, but there's this very large eccentric soft plaque, non-calcified plaque. You can see in the cross section, there's dye in the middle of the blood vessel, but you can see this huge amount of non-obstructive plaque that's eccentric, that's outside of the blood vessel wall. And these have been shown to be very high risk for rupture and heart attack. So again, here's a patient who has a normal perfusion scan with actually a big problem. Now, in fairness to nuclear imaging, nowadays we do CT attenuation. So we do get a very low level CT scan that can pick up some calcifications, but we're not doing a CT angiogram. We're just doing a non-contrast scan. So we can pick up some of these patients with normal nuclear scans that do have calcium. And this is, again, sort of another study looking at this risk. These are patients who underwent a CT angiogram who had less than 50% stenosis. Again, something that we would consider non-ischemic, but you can see if the difference in outcomes over 3 years, non-obstructive disease versus no plaque. And again, depending on how much disease there was, 1 vessel, 2 vessel, or 3 vessel disease, the risk increased incrementally. So even in these patients who don't have what we would call severe blockages, did have increasing risk. So that's all fine and dandy risk. If you have disease, you're at risk, but does identifying this disease make a difference? If we say you have coronary disease, does that mean anything? And I think the answer is yes. This is the Scott Hart trial, which was also a CT trial where they looked at patients who had stable chest pain, and they randomized them into 2 groups, one who underwent standard evaluation and treatment, usually with stress testing or stress imaging or CT angiography, and they followed them for 5 years, and what they saw was there was a significant difference in terms of death from coronary heart disease or non-fatal infarction, or non-fatal infarction alone as an endpoint in those who had a CT angiogram. And the question is, well, why was this difference? As it turned out, there wasn't a higher number of coronary angiograms or coronary revascularization between the 2 groups, but there was a substantial difference in preventative therapy. So those people who got who were identified by CT to have disease got a statin and got an aspirin. And the authors speculated that it was this preventative maintenance that was the important reason for the differences in outcome. Now, does identifying disease actually result in changes in lifestyle? And the answer is possibly not. This is called the Promise Heart trial, which was another CT trial looking at comparing patients who underwent CT angiography versus functional testing. And you can see that, as in the Scott Hart trial, there was an increase in use of preventative therapies, aspirin, statin, beta blockers, in the group who got CT angiography. But when you looked at lifestyle changes, there was no significant difference in exercise, quitting smoking, or weight loss. And so I think this is potentially a place where maybe group medical visits might be able to help, because I think, again, this personal lifestyle change, we're not getting it done in the clinic. And then finally, this trial, which I think is an important trial, kind of a busy slide, but I think an important conceptual trial. There have been multiple trials looking at randomizing patients to medical therapy or conservative therapy versus invasive therapy with stenting. This was a large study, 5,000 patients. And in order to get into the trial, you had to have an ischemic abnormality, moderate to severe ischemia on a stress test. Most of them were nuclear stress tests, some stress echoes. And they randomized patients into two groups. Now they did look at their coronary anatomy. Most of them had a coronary CT scan to rule out left main disease. So if you had left main disease, you didn't get recruited into this trial. But if you had significant ischemia and obstructive disease, you got randomized to one of these two strategies. And the bottom line was that even in the presence of significant ischemia, medical therapy did just as good as interventional therapy. So for example, the patient that I presented who had chest pain, stable exertional chest pain, she could have been easily treated with medical therapy and not undergone a stent. And I've seen several of my patients who, not to say that coronary stenting shouldn't be done, I think it's got its place and its role, and it's helpful in many of my patients, but many of them, it's sort of the idea that they had a coronary stent really throws them for a loop, and they just are convinced that they're going to have another stent and they need another angiogram, and then they're identified as a cardiac patient. So they come back to the ER, and immediately, if you've had a stent, you're a cardiac patient. Even if you have abdominal pain, well, it might be that stent. So it really does have an effect on your life. But I think this is an important trial, saying it's safe to treat those patients conservatively. And then finally, this trial, the Orbita Trial, which was, I think, a really unique trial. I don't know how they got this through human subjects, but patients with one vessel disease were randomized to either getting angioplasty or a sham procedure where they cath them and didn't intervene on them, and they didn't tell the patient what they did. And then they followed them to see if there was any change in exercise time, which there wasn't, not statistically significant. Anginal frequency didn't change. And there was a difference in freedom from angina, but you can see in the patients who had a angioplasty, only 50% of them had freedom from angina. And actually in the placebo group that got the sham procedure, didn't have a stent, 32% actually had resolution of their angina, suggesting there's a significant placebo effect just associated with getting a heart catheterization. So when should we start looking for coronary disease? This was just published, I think, a week ago or a couple weeks ago in JACC journal. And essentially they tried to predict, based on coronary calcium score, when should I get my patient when should I look for disease? And they came up with an algorithm to say the optimal age for getting a coronary calcium score would be 37 years if you were a man, or 50 years if you were a woman and you had diabetes. Or if you had no risk factors, 42 years old for a man and 57 years for a woman. And so this test is available. It's hard to get insurance to pay for it all the time, but it's relatively cheap. I don't know what Meritor charges for it, but I think it's less than, it's in the $100, maybe at most $200 range. So I'm not saying that's cheap, but it's not a wildly expensive test. Now, let me just switch gears for a second and talk about this idea of personalized care, which I think is coming of age. And for me, I think that one of the lessons I learned was that we're all different, that just because something works for me or works for someone else doesn't mean it's going to work for you. And I like this. This is a paper entitled The Unidentified Hormonal Defense Against Weight Gain. And they were speculating about why it is that some people seem to gain weight and others don't. And it talks about this genetic lottery of life, that you get these genes randomly from your mother and your father. And in an environment where calories might be restricted, nobody has an obesity phenotype. But if you transfer that population into modern day obesogenic environment where there's hamburger stands on every corner, ice cream shops, and what I call candy coffee, this same person in that environment might remain slender, but another person in the same environment becomes obese. And so I think recognizing this background difference that I don't think we completely understand is, I think, important to have compassion for people who have trouble losing weight. And then this over on the right, which is the doctor who's, clearly exercising in his running suit, talking to this patient who's a little bit overweight, and the patient says, "What's the verdict, doc? Exercise." And the implication is, well, if you just did what I did, if you exercise more and ate less, you wouldn't have this problem. Look at me, I do this. So I think this was a lesson for me to say, hey, not everybody can do under the same conditions is going to have the same outcome. And this kind of data, I think, really we see this in the animal literature. This is the UW is sort of famous for their calorie restricted study in the rhesus monkeys population, showing an improvement in longevity. And there's a lot of information out there about, well, if you calorie restrict, there's not only an improvement in weight, but also increase in lifespan. And this was published recently in Science Journal by Matt Kaberlein, who's really involved in longevity studies and looking at various dietary restriction studies. In mice, this was looking at calorie-restricted diets, and flies looking at protein-restricted diets, and then in yeast looking at glucose-restricted diets, which have all been shown to be associated with prolonged longevity. But what he points out is that what's plotted here along the x-axis is genetically distinct variations. So mice of different genetic backgrounds. And one of the things to recognize is that most of the mice studies are done in genetically similar black 6 mice. So they're all genetically identical in a lot of trials. But in these trials, these were male mice and female mice that showed substantial variations in longevity in response to calorie restriction. Same thing in flies, and same thing in yeast. So not all these restricted diets necessarily work depending on your genetic background. And we see this in human trials if you kind of dig into them a little bit. These are two recent trials. One, the Diet Fits trial that was very popular. This randomization, Christopher Gardner, where he took patients and put them on a low-carb diet and another group on a low-fat diet to try to finally decide which was better at resulting in weight loss. And the outcome of the trial was that they both were successful on average. People lost weight on both diets. But if you look at the individual plots of people involved in these trials, you see this wide variation in weight change. Overall, more people lost weight on a low-fat diet and on a low-carb diet, but there were several patients in both groups that actually gained weight. And why that is, we can talk and debate about, but the reality is not everything works. Not everybody's responds to one diet or another diet. And this other trial on the right is Ethan Weiss looking at a calorie-restricted or time-restricted diet. So he compared time-restricted, I think it was an 8-hour window of eating, and you fasted the rest of the time, versus patients who had consistent meal timing, so 3 meals a day. And again, the outcome was that there was no overall difference. Both groups lost some weight, which may imply that just entering a trial may be a way to lose weight. But again, you can see there were some people who gained weight in both groups, and some people who lost quite a bit of weight in both groups. So again, we're all different in the way we respond to these different approaches. And this is another example of that, glucose variability. This is from a trial where they put continuous glucose monitors on patients. And these are just 2 participants in this trial. One looked at the response of glucose to eating a banana versus eating a cookie. So here's a person who had a significant glucose spike after a banana, but not after a cookie. And here's a person who had a significant glucose spike after a cookie, but not a banana. And so this glucose variability, which I think has a lot to do with early development of diabetes and risk for diabetes and subsequently cardiovascular disease, is important. And this trial, which I thought was really remarkable, was done by Aaron Segal in Israel, where he basically took patients and tried to predict what diet would be the best at controlling their blood sugars. So he took 800 people. He put the continuous glucose monitors on them and had them keep a food diary. So they had all this continuous data of what foods cause spikes in blood sugar. And then he looked at microbiome data, blood test data, questionnaires, food diary, height, weight analysis, and he plugged all that data into an algorithm and outplopped for each patient an individual personalized diet. And he was able to predict what foods would spike sugar based on this analysis and determine whether that improved patients' glucose spikes. And what he saw here was that the glucose spikes after starting the algorithm-based diet significantly decreased. And when he plotted it, hemoglobin A1C, you can see that on the algorithm diet after 6 months, significant reduction in hemoglobin A1C versus placebo. And that was even better than patients who were taking metformin. So again, this idea that you can predict individual patients' response to certain lifestyle changes and dietary changes, I think, is important. And this might translate into some of our patients. I present this primarily because I'm going to propose that we think about possibly doing this kind of work in the group medical visit. But this was a very small study in patients who had percutaneous intervention, and they put glucose monitors on them, and they identified a group that had this low amplitude of glycemic excursion, which means essentially they had lower glucose spikes following a meal, and then a group that had high glucose spikes after a meal, and just followed their event rate, cardiovascular event rate, and they showed this substantial difference between the low glucose and the high glucose groups. This suggests that you might be able to come up with some way to figure out who is at higher risk for cardiovascular events. And then this study, which was looking at different quartiles of glucose variability, quartile 1 was those who had very low glucose variability, and quartile 4, very high glucose variability. And over time, you can see that those who had the highest glucose variability had the highest incidence of cardiovascular disease and mortality risk. So again, this might be a surrogate marker for those who are at increased risk. I'm going to skip this one just because it's too much detail, but the other thing that might be worthwhile investigating is this idea of using smartphone apps. This is a trial from Stanford where they actually just gave people an application on their phone to track food, and they actually, all they did in this first group was say, all we want you to do is enter the food that you eat. And you can see that over a pretty short period of time, there was a significant weight loss just by people tracking their food. There was some added benefit if they got some counseling associated with it, but just the fact that that patients who track their food, and that compliance was the key, that those people who actually track their food had the most significant weight loss. So this might be a potential strategy as well. And one of my ideas was to propose thinking about what can we do in the group medical setting that might be show that we're having some impact. And I've had some conversations with the Dexcom company about giving us continuous glucose monitors, and there are free cell phone apps that we could use, and we can randomize patients into those who attend the group medical visit and have access to a continuous glucose monitor and the data, another group who maybe are blinded to the data, and then a third group who just get the glucose monitor and don't have the data, and then analyze, are patients doing better by attending the group medical visit alone, or do they need this background information, and does the food app help? So, if anybody's interested in that kind of thing, I think it'd be a huge project, but something that we might be able to do to sort of, again, help justify what we're doing in the group medical setting. And then finally, making change. I think this is, again, one of the biggest focus of our group medical visits, and it's hard to do, but it can be done. And this is kind of the way I kind of like to think about this. And again, Katie really is the person who I think has convinced me that really this needs to be the focus. It's not so much about teaching people about their what they need to do, but rather helping them to change and choose habits. And I got this actually from a woman who, a video that this woman who does yoga, and she ends each session with this sort of mantra of, we all have negative habits we carry with us every day, but we can choose to change those. And she talks about starting at one breath at a time and then moving on to one identity at a time. And I kind of like this way of thinking and kind of how we progress people through the group medical visit. So one breath at a time, we begin each session with a meditation. Katie leads the meditation, and we encourage, and she encourages people to take up a meditation practice. And we, explain how meditation might be helpful to people. One thought at a time, a breath becomes a thought. So we have the patients take a personal health inventory, and we work them through the workbook where they start with identifying the change, where they're at with their health, and looking at their inventory, and then ultimately selecting what it is they want to focus on and where they want to try to make change. So a word or a thought becomes a word. So then once they've had a chance to think about where they want to go, they come back and they share with the group what is the goal that they want to achieve. So they have to put it, we ask them to put it both in writing and then also to share it verbally with the group. And then a word becomes an action. Each week when they come back, we talk about, how did you do this week? What were the stumbling blocks? If you weren't able to achieve your goal, how do we help you adjust and make it happen so that you can actually achieve one of your goals? And then an action becomes a habit. And so at the end of the session, we really have shared in successes. We've had some beautiful stories that people have shared about things that they were able to accomplish, and we encourage consistency. And then the ultimate goal is to make a habit an identity. So for example, I'm a runner and therefore I run. I'm not a smoker and therefore I don't smoke. And we tell people that this might take more than a year and we need to be patient. But I think we find that, or one of the things that I think we need to think about is, how do we bring patients back so we can see, are they on track with this kind of thing? Because they sort of disappear after the 6 weeks. And I know there's been a lot of work in talking about how do we get people back for a check-in and maybe another group visit, but we really haven't formalized that. And we encourage patients to get the big rocks in first. I think people are familiar with this idea, but the story goes, the professor comes into the class and has a jar and puts some big rocks in it, and he asks the class, is the jar full? And they say, no, or yes, it is full. And then he puts some pebbles in, and he says, now is it full? And they say, well, yeah, now it's full. Then he puts some sand in and finally some water in. And he says, what's the lesson? And the students say, well, the lesson is that you can always get more in. And he says, no, the lesson is that if you don't get the big rocks in first, you won't get anything else in. You'll never get them in. So what are the big rocks? We try to focus on this in the group, and it turns out the big rocks are sometimes a surprise to people. This is kind of a famous study from back in 2010 where they looked at what attributes were associated with increased lifespan, and it turned out things like social integrations, close relationships, really far outweighed things that you would expect to be at the top of the list, like hypertension treatment. Not to say that these aren't important, these other things, but in comparison, not to forget these sort of social aspects of life. And this sort of says the same kind of thing. This is looking at added years of life compared to a sedentary lifestyle. And you can see that what seemed to have the most advantage was these more social sports. Tennis, badminton, and soccer seem to be better than sports that are maybe done individually, like going to a health club or jogging. So again, this aspect that social interaction is important, we try to stress. And this is just a list of sort of some of the graduates, some of the quotes from them that I'm kind of proud of, and I think says that we're maybe doing something positive. So one of our first patients was on metformin, and after the 6 weeks, she told us that she'd actually been able to get off metformin altogether, which was quite a remarkable achievement. I lost 5 pounds. The woman who completed the first 5K run was really a person who came full circle on this. She was one of my patients. She'd had a coronary stent put in and a heart attack. She decided she was going to do the couch to 5K run, and during the course of the 6 weeks, she actually trained and got this accomplished. And she told us about her experience, and she shared that she was carrying a bottle of nitroglycerin with her on her runs because she was so fearful that she was going to have a heart attack. And I was actually shocked by this. Another patient of mine in the group pulled out his nitroglycerin bottle and said, you know, this is the best friend I hope I never need, he called it. And I had no idea that both of them were walking around so fearful that they were going to have a heart attack that they never, ever left their house without their nitroglycerin. And this woman was running with her nitroglycerin bottle. But when she completed it and, you know, felt now safe that she could actually achieve something like that, it was really quite remarkable. And I just saw her in the clinic. This was probably 2-3 years ago now, and she's a runner. She runs 4 or 5 days a week on a regular basis, and she feels bad if she doesn't miss it. So she's kind of one of these people who changed her identity and now identifies herself as a runner. Some of the other things that you can look at that I think are neat. This guy had never cooked a meal before. He was in the teaching kitchen, and we taught him. Actually, it was quite remarkable watching him try to learn how to cook. But he took the recipe home and he went to the grocery store and he cooked a family for his meal for the first time, which was really kind of neat. My husband and I started eating dinner together. I cleaned out my cupboards. I really started thinking about what I'm eating. This patient who very emotional, talked about how he desperately wanted to get back into his military uniform for Veterans Day and was able to achieve that. Just some simple things. This patient who made his first appointment in cardiac rehab had peripheral vascular disease, and there was another patient in the same session who started a walking program who had peripheral vascular disease, and he wanted to go on an elk hunting trip with his friends that he had been doing on a regular basis, but hadn't been able to walk the distance. And actually, over the course, his goal was to be able to walk 5-10 miles, and he actually achieved it. But this other patient was just getting going was his big problem. It wasn't that he wanted to go on an elk hunting trip. He didn't have that high of goal, but the other patient encouraged him. And finally, he shared with us that he made the step to actually make a cardiac rehab appointment and start it, which was a huge milestone for him. And I just got a note the other day from cardiac rehab to renew his prescription to go to cardiac rehab, that he was continuing to go there. Or just something as simple as I stopped at the gym on my way home from work. And then I just wanted to finish with this idea of the vulnerable individual beyond the heart. And I think this is where cardiology has really changed over my career. When I was in residency and fellowship, really cardiology was so focused on the coronary lesion. It was about stents. Stents came out when I was a fellow. And it was about treating and finding blockages and treating them. And I think we've evolved to figure out what blockages need to be treated. We have fractional flow reserve now. But this switch from a lesion focus to a patient-centered approach, and the idea of early detection and preventing being really the key, and intervention, while it has its role. My interventional colleagues, I hope none of them are listening, because they'll say, are you saying intervention is not important? It is. But I think this side of the coin is really an important part as well. And then this idea that aging seems to be a target is also, I think, something we need to watch for. We think of aging as inevitable. We think of chronic disease as treatable. The problem is, once you have a chronic disease, it's oftentimes very difficult to treat that. So the idea that aging might be a target for health, I think, is gaining some ground by focusing on preventing aging instead of waiting for a disease to emerge and then focusing on treating a particular disease. We might have better success. And I think this crowd knows this better than I do, which is we need to stop doing sick care and start doing health care. So I'm not telling anybody here anything they don't know, but I'm a cardiologist. And this idea, I think, is coming forward. This is a trial that you guys may be familiar with, the TAME trial, which has been put on hold because of COVID. But the idea here is to use a drug, metformin, which is readily available, which seems to have some potential anti-aging properties. And the trial here is the concept of the trial here is to take people who have one of these 5 chronic diseases and randomize them to placebo or metformin and study whether metformin maybe prevents the onset of one of these 5 diseases. So the idea is to push the FDA to recognize aging as a potential target of therapy and potentially reduce the onset of one of these diseases, not just focusing on one chronic disease, but a constellation of diseases associated with aging. And this idea, I think, is gaining traction. I don't know if you've read about this in the news, but Altos Lab is a cellular reprogramming or cellular rejuvenation company that just got a $3 billion loan from billionaires like Jeff Bezos and Yuri Milner to study rejuvenation therapy. And Dr. Yamanaka is on their scientific board, and Jennifer Doudna is also on their board. And these are 2, Nobel Prize winners. The Yamanaka factors were discovered. These are protein factors that seem to reprogram cells from a fully differentiated cell back to a pluripotent stem cell or to a younger cell, so to speak. And Jennifer is the person who came up with the CRISPR gene editing tool. If you haven't read this book, The Codebreaker, which is the story of discovering CRISPR technology, it's worth a read. It's really a fascinating book. But up here in the upper right-hand corner is just a proof of concept. This is from David Sinclair's lab at Harvard, where he took these Yamanaka factors and studied it in mice who underwent a crush injury of the optic nerve. And after giving these Yamanaka factors, the cells returned to sort of their younger self, so to speak, and regrew the optic nerve. And essentially, the idea is these Yamanaka factors made the cells young again, back to their youthful state, and they were able to differentiate again into nerve cells. So I think this whole field of research is really fascinating and something that I think we need to kind of watch as well. And this has trickled into the cardiology world as well. This is from 2020 American College of Cardiology paper where they described different strategies to decelerate biological aging. And I think we're currently stuck with the behavioral things, physical exercise being probably number 1, dietary patterns, salt restriction, avoiding alcohol and smoking. I think we're still waiting for better evidence about calorie restriction and fasting, but these are also potential tools in the tool belt. And then there's a whole series of drugs which are potentially promising. Metformin, we just talked about. Rapamycin, every animal model that's used that has shown an improvement in longevity. And actually, I'm getting involved with an NIH grant with one of the UW providers looking at this and the potential cardiovascular benefits of this drug. Also, some anti-inflammatory drugs have shown promise, particularly in cardiology. SGLT inhibitors have shown cardiovascular benefits, but also some people are suggesting that this may be actually a longevity drug. Acarbose is another drug. So there's some cool pharmacologic therapies that are also on the horizon. So in conclusion, I would say that detecting coronary disease and disease burden is key, and this can start the process of prevention. And I think we're able to identify patients at an earlier stage that need prevention. And then once vascular disease is detected, I think a focus on personal behavior becomes the primary focus. Making change is hard, but I firmly believe that the group medical visit can help with this, and we've seen evidence that that's the case. A change can work to improve cardiovascular health and likely extends most other prevention of other chronic diseases. So a combination of early detection, personal behavioral changes, and new pharmacologic therapies will hopefully be key to extending healthy lifespan. So that's all I have to say. I'm happy to answer questions if people have them.